current hepatitis C treatment guidelines. We are facing a new era of explosion of knowledge in the treatment of chronic hepatitis B and C. Local government, young government as well. We have Nirmaji and the Society has decided to draw a new 2013 guideline a month ago, and we have modified our old guideline, 2009 guideline. This is disclosure. For the benefit of junior colleagues, in all the presentations in the international meeting, you have to state very clearly that within this presentation, I do not have any financial support from any company to say the benefits of their company's drugs. I have to. Or else, you can say that I'm on salary payroll from the MSP company or a company, something like that. It is disclosure. You have to tell the audience that, so that the audience can decide some of the points the presenter stated are biased or not. This is the standard practice. And I would like to start off with the take-home message. Usually take-home message is at the end. So I would like to start with take-home message. From this presentation, you have to know that the new developments in ACV treatment are happening. Development of the directly acting antivirals. The usual standard therapy for the treatment of chronic hepatitis C is injecting pegylated interferon and the ribavirin. Pegylated interferon is not an antiviral agent. It is a drug that enhances the host immune system to fight against the hepatitis viruses. So it is not antiviral. Ribavirin, not very clear, some effect on the immune, but we are now having a new era of antiviral drugs that directly affect the host genome, ACV genome. The good news is that with the antiviral drugs, now we are achieving 100% cure rate, approaching 100% cure rate. And last month, United States FDA has approved 2 new drugs, oral drugs, Samiprevir and Sofosbuvir. These 2 drugs alone can do without pegylated interferon or without ribavirin, and the cure rate or sustained viral rates are approaching 90%. So with the opening up of our country, these drugs will be available in our country in the very near future. With this background knowledge, we try to update our hepatitis C guideline. The other is laboratory testing, ACV RNA testing. You will probably still be seeing a lot of laboratories still doing quantitative ACV RNA, positive, negative. That should no longer be used. You're wasting your money, your blood, your time. It should be completely highly sensitive, real-time PCR machine that can measure the ACV RNA, the viral load, down to the lowest 12 copies per ml, and the highest more than 100 ml per ml. So the ACV RNA testing, and we are having now fully automatic ACV RNA tests. The previous ACV RNA, you will probably know in the PCR, you are detecting a genome. You have to be very cautious about the contamination. The room is clean room, dirty room. You have to wear clothes, change your shoes and everything. No. This is completely new, fully automatic. You take out the blood, put into the machine. Wait, you play Facebook or whatever, or your chit chat and with all of it. And 4 hours later, you get the results. That's all. So these machines are available in our country. The other biggest change is a must-know thing is the IL-28, the G polymorphism. For the clearance of the hepatitis C virus, there are host factors and viral factors. Viral factors, virus genotype 2 has the best response. Genotype 1, particularly 1A, is the worst response. The viral factors. How about the viral load? About 200,000 IU per ml. High viral load, very difficult to cure. Low viral load, you can cure easily. That is the viral factors. How about the host? Black, American Negroes, very bad response. And high BMI, overweight, bad response. Diabetes and glucose intolerance, bad response. And alcohol, bad response, poor response. But it's a great but. We now understand also the host IL-28 gene polymorphism is very important in the response, particularly in the genotype 1. In the West, the genotype 1 response is around 50%, less than 50% cure rate. In our country, our data are conflicting against the Western data. We are seeing around 86 to 90% cure rate. We don't know why. Now we understand. Myanmar people, majority of the Myanmar people have IL-28 gene polymorphism, CC. IL-28 is the gene မှာအဲ့မှာတော့ပြီးပြောင်းတော့ CC ဆိုတဲ့ allele ရှိလို့ရှိရင်သူကပြောင်းလိုလိုကိုပြောင်း CT ဆိုရင် very difficult to treat. TT very difficult. So Myanmar people IL-28 gene polymorphism, majority are CC. So in cases of genotype 1, difficult to treat genotype 1, if the patient can afford, now we can test IL-28 gene polymorphism by sending the sample to Singapore and you get the results within a week. CC, oh, you get a cure response. We can even apply the early stopping rule. Instead of treating 40 weeks, we can stop at the 24 weeks. But if you're CT or TT genotype, no, you have to take the treatment for 40 weeks and maybe we have to expand to 72 weeks. That is very, very new and available in our country. The other is fibroscan. Fibroscan is now the biggest thing in the use of fibroscan is it is now approved by the United States FDA. You know very well, US FDA is very difficult, to approve certain procedures, items of the drugs. Now it is approved. And by using the fibroscan, you can stage a person's fibrosis, 0, 1, 2, 3, 4 cirrhosis. Or you can stage a person's steatosis, 0, 1, mild, moderate, severe. So with that knowledge, you can modify the drugs to reduce the steatosis, to reduce the fibrosis. So these are the changes. And the extension rules. Previously, we say genotype 2, 3, 6 months or 24 weeks. Genotype 1, 14 weeks or 1 year. Now no. Depending upon the pharmacokinetics, you may have to extend the treatment in certain patients to another 6 months. For example, genotype 2, 3 may be treated for 1 year. Genotype 1 may be treated for 72 weeks. So these are the take-home message of my presentation. These are the new developments. With this introduction, I would like to move to the Myanmar GI endeavor treatment guideline. This is Myanmar data. We are one of the countries with a very high incidence of the chronic hepatitis B. Hepatitis C is very dangerous. Why? Because this can cause HCC. That sometimes even professors, doctors tend to forget or cannot accept. I know some very senior doctors having anti-HCV positive and they don't take treatment. They don't want to face the reality. But the fact is that now we can cure the hepatitis C virus. Unlike hepatitis B, cure, not suppress. Not like HIV. HIV you can suppress the virus, but you have to take the medicine forever, antivirus. But in the chronic hepatitis C infection, not only suppress, we can cure, we can make a person clear of the hepatitis virus. If a person is negative at end of therapy, we call it end of treatment response, and 6 months later, you test it again, and it is HCV RNA is negative, you call it sustained virological response, SVR. That means cure. It is, according to the international studies, it is well accepted that once a person is negative 6 months after stopping the therapy, achieving the SVR, 99% of the people will never have recurrence. I don't know. Here, treatment over we should. So the message here today is again, one of the main reasons is that to arouse the awareness among the medical professions to the importance of HCV infection, which can lead to cirrhosis, which can lead to ACC. And it is now preventable for the progression of the disease to ACC or to cirrhosis of the liver by very effective antiviral therapy. And in the next 2 or 3 years, we'll be having interferon or ribavirin, just 2 oral medicine. You can have 100% cure rate. Those who have been treated, not successful, relapsers, don't worry, wait for 3 years. And you can have, or wait for 1 year, you can go to, if you can afford to go to Singapore and have the treatment, you'll get 100%, almost 100% cure rate. This is main message today. So how about the NEMA data? In the ACC, HBV DNA 46, HCV 23, and all of the we also have our own NEMA data, which is published in the journal.